Then from there on, we learn to understand immunity, cross-matching, get all the tools that we have now to have successful transplantation. Then we found the concept of multi-drug immunosuppression to decrease the toxicity and to enhance the survival of the graft. Next, please. Then we go about the 1980s. 1980s was an era that was phenomenal for all of us because we started having legislations that designated that pediatric transplantation was a treatment of choice for many aspects of end-stage organ disease. We proceeded to develop new immunosuppressive medications and organ preservation and monitoring from anesthesia, ICU that made transplant a reality, that this was going to be a therapeutic modality. Next slide, please. Then we come to the culmination in which transplantation is decided to be by the governments the treatment of choice for the terminal organ failure. We finally were able to develop an experiment that was transplantation from the bench to the clinical practice safely and with producible effects at all levels and multiple countries and multiple situations. We brought a science to the present time. Next slide, please. If you look at the outcomes over time, are dramatic improvements. Dramatic improvement in survival, dramatic improvement in how we are able to decrease the presence of rejection and prolong the survival of these organs through better matching, immunosuppressive agent, technique, preservation, imaging, you name it. We got to the point. And when we get to the 2017, what were the challenges? What are the challenges of our days? Well, let's talk about now a specific aspect. We want this transplant to be available to everybody, so access to transplant cost is a priority for us. We have brought technology for early diagnosis of rejection. We have brought technology for self-assessment of medical care. We have apps. We have technology through computer services, systems that we can help the care of the transplant patient. Now, in the area of prolonging the function, we have so many aspects in which we improved. We improved also in other aspects that today we are developing. But now, we even go further. We are able now to develop organelles that eventually, in the future, we are able to create in the lab and create a mass quantity to replace graft function. Next slide, please. And when we have to sit down today in a meeting, we have to go next slide, please. Next slide. Yeah. Now, when we have all this success in clinical practice, research, immunosuppression, we have to sit down and think about it. What are the goals that we have for pediatric transplantation? And I want to encourage you to think about these 4 goals that should be our paradigm of why we do what we do every day. When we are treating children, we can all agree that the reason why we have goals of the renal transplantation in children are, number 1, to restore renal function to the most optimal level. We all know that we need optimal renal function for the child to develop, to growth, and all aspects needed for them at this stage in their lives. The second aspect that I want to encourage you to think why we do this is to provide the longest graft survival lives to help children to achieve full potential for growth and development. It's not about 5-year success. We want 10, 15, 20 year success of this graft to provide the best environment for these children to develop their full capacity and to be useful and productive citizens that can develop a productive life. This is needed with an adequate and optimal kidney function. Number 3, we want to give the children the best quality of life. We want them to be with the best renal function, avoid hypertension, avoid electrolyte balance, avoid dehydration, We want to give a quality of life that they can enjoy life and become the best that they can be. And overall, safety at all times. Every type of procedure that we do, every type of transplant to have safety at all times. Next slide, please. After we have seen our success, then we come to the question, when is appropriate not to transplant? And I'm not going to bring here a double-blind study, randomized studies, retrospective meta-analysis. This is going to be to sit down here together with you, and we're going to start thinking occasions in our careers. I have been 30 years doing transplant, and I want to say there are a few cases in which I'm going to look back. I will not do them again because we didn't do the right things for these children. And I want, next slide please. And I want to suggest that there are several causes and several aspects in which make children not a candidate for transplantation and where we should not transplant. Some of them are recipient-related conditions. Some are related to age, multi-organ dysfunction, malignancy, infection, active autoimmune disorders, neurological disorders, degenerative disorders, non-compliance, and lack of adequate support. If we really think about it, in all our careers we have had to take care of these children with some of these conditions. And I hope that after this talk we can all in mind that our goal is to use every organ in a child for the best result and outcome. Next slide, please. When we talk about age, when is an age that we should not transplant? Looking at the guidance published already in our society, say that children less than 6 months of age should not be considered appropriate for kidney transplant. This is a concept in which may not be completely solid, but it gives an idea that we need an adequate development, adequate cardiac output, adequate pulmonary function for these children to do well. So therefore, less than 6 years of age probably is not the adequate, we should not be transplanted to children. We accept commonly and probably throughout our practice that 18 months of age is or older are commonly accepted for kidney transplantation. And the reason is that by this age we have a heart that can accept extra volume, we have lungs that have developed and probably overcome the trauma of early prematurity or large lungs or every other reason that have injured these lungs, and they have probably in better shape. Weight more than 10 kilos is a surrogate of development in which we in our center have adopted. And most important than all, we transplant the patient when they're in the optimal nutritional status. This is something that I believe very, very, very strongly. Children that are not in the best nutritional status, low in protein, clotting factors are deranged, they don't have good overall performance and multiple infections, are not in the condition to be transplanted and should be optimized before transplant. Next slide, please. Multi-organ dysfunction. These are the areas in which we have to say, probably have to think twice before we transplant them. Most important, some of the children have to say probably too much anomalies that can preclude a transplant. These are patients that have severe congenital anomalies in which aggressive and extensive cardiac disease are still not going to solve completely or have adequate palliation. And this is a very important aspect in the sense that severe congenital anomalies with kidney failure are very difficult to manage in the postoperative period. And these are the aspects that we have to seriously think. Are these children are going to benefit with complex surgery plus cardiac surgery? And I leave that up to future discussions in which we all can bring our experience and bring some points about it. Pulmonary maturity and insufficiency. This is an aspect that we carefully have to evaluate these patients. Premature patients with polycystic kidney disease, children with prematurity, suffer significantly in the post-natal period with respiratory insufficiency. These children have to be carefully evaluated. Some of them we have to say we cannot transplant at this time and mostly have to wait for a period in which the lung functions are improved. Ventricular function, as you know, is a corollary of capability to tolerate a transplant. Any type of process that has cardiomyopathy or deficient ventricular function or diastolic dysfunction, we need to be considering that some of these patients, if it is severe, they are not a potential for candidate for transplant. And advanced liver disease is a condition which we have to really be careful on all these patients. Next slide, please. In the area of malignancy, one of the ones that affect us the most is Wilms tumors. And it has been across the board accepted that Wilms tumor less than 2 years of remission probably, except if there's an early stage or a very small tumor, should not be transplanted unless you have 2 years of remission after multimodality treatment. Any other uncontrollable malignancy, this may be solid organ or might be hematologic or bone marrow malignancy, should be considered not for transplant unless they are fully controlled and metastatic disease. Next slide, please. Active infections. This is an area in which we all have to be always aware. Systemic infections, especially when they're related to tuberculosis and systemic fungal infection. In our environment, we have a significant amount of tuberculosis on children, in which we have to make the decisions. The transplant is not in their presence for transplant, but hopefully after 9-12 months of treatment and the disease under control, we can proceed with transplant at that time. Obviously, hepatitis B and C, these are, even though we have great antivirals, still considered when they're active and still replicating a contraindication for transplant, we should not transplant them. In the area of EBV and CMV, this is something that we probably, everybody in their own experience, would have to decide when is the right time for these patients. EBV, active EBV, should be a concern in which we probably should consider not transplanting until we have adequate viral control as well as TMV. In our area in which systemic fungal infection as coccidioidomycosis or plasmosis are endemic, this is one of the considerations that we have to have this disease on a controlled state before considering for transplant. Next slide, please. This is one of the areas in which we all have to face that are the autoimmune diseases. All of us can agree that a patient with active atypical hemolytic uremic syndrome, that the markers show activity, should not be the time to transplant this patient. Same thing, patients with children with mixed connective tissue, we find that all these patients need to be under control in our center. We have to be under control with minimal immunosuppression, that consisting of prednisone of 5 milligrams, or if you use mycophenolate mofetil, less than 200 milligrams per meter square on these children. Same thing goes for Wegener's, large vasovasculitis, and systemic lupus. All these patients expect and want them to be under control, completely with no activity on the disease prior to get active for transplant. We just had a child that we did not expect to see in the workup. We found have active aortitis with active inflammation of the aorta. This is the type of patient, even though it's really difficult to dialyze him, even with the active vasculitis, is a concern for not transplanting this patient. Next slide, please. This is one of the very difficult areas that we probably should have follow up in this Congress. What are the diseases in which should be transplanted? Which ones should not be transplanted? As a general rule, we consider in our center that debilitating irreversible brain injury in children should be strongly reviewed and assessed as candidacy for transplant. If we consider that the deterioration or the injury is so profound that there's severe delay on mental function and development, we would not consider these children for transplant. Uncontrollable seizure. We have several of these children which require 2-3 agents for management of the seizure. These children we would not consider for transplant at the time due to the fact that, as you know, Medicaid or immunosuppressive agents decrease the threshold for seizure, and they are not conducive for a good outcome. In the area of systemic degenerative disorders, is an area that is still a lot to be learned. When you study several of the lysosomal disorders or the mitochondrial disorders in which there's a systemic progression of the illness, with knowing carefully that the transplant of the kidney is not going to control these degenerative diseases, it's difficult to consider these children to transplant, and sometimes, and most of the time, these children are not considered in our center for transplant. Next slide. Any type of disorder shorten the life expectancy that does not resolve with the kidney transplant, in our center, we consider that are not transplant candidates. One of the challenges that we have at this day and age is the Schmenke syndrome. Schmenke disorder that includes renal disease, immune disease, and connective tissue. There are several of these children in which, in controlled trials, have been offered kidney transplantation. And in the post-op period, some of them, if they don't have enough penetration, they can do well. But other ones with significant penetration, they have vascular accidents as carotid thrombosis, stroke, multiple malignancies, especially osteosarcoma, and the outcome in the next 5 years is not favorable. In our center, we are evaluating these children very carefully to see if these children are able to be transplanted. Some of them, if they have any manifestation of secondary malignancies, we do not consider them for transplant in our institution. This is an area that is very difficult. Next slide, please. Non-compliance. Non-compliance is one of the difficult areas in which which both face. What a teenager in which has demonstrated that cannot be compliant on the diet management, on the medication management, on the fluid management for dialysis, it's difficult to imagine that these children will become good candidates for transplantation. And sometimes we have to say it's not a candidate until, by training, by support, by maturity, they can become compliant with the medication consistently. We consider these children not a candidate until all these factors are obtained. It's very important that there's a multidisciplinary approach between our nutritionist, our social worker, our psychologist, and our medical team to try to make this decision. As you all know, a poor outcome on the first transplant means for these children that they are highly sensitized and prolong their next transplant and prolonged time on dialysis. Next slide, please. We all understand very carefully that these teenagers have a lot of pressures, social pressures, learning, stress of life, all these aspects. We are to have a concise approach to try to offer these children the best outcome with transplantation. Next slide, please. In our area, hopefully not there, we see a lot of lack of adequate support. Unfortunately, a lot of with our approach of both parents working, immigration, single parenthood, all of these presents these children challenges for the medication compliance, clinic visit, close surveillance for clinical conditions, and resources to bring them when the time of complication comes about. Adequate support is what capital needs for all these children, and when there's not adequate, we have to say probably it's not the right time and we should not transplant them until these aspects are under control and are provided. There are donor conditions also that are related to, next slide please. There are donor conditions in which we are, for pediatric transplant, to consider that is not organs that we transplant these kidneys, for these children. One are margin quality function. In adults, we will not think twice to offer this kidney for adults because we can offer 2 drafts, or if it's an elderly patient that has a limited 5 years, we can offer these organs. Children, we should not offer this type of organs because they will not offer a quality of life, neither the length of graft functions will make a difference with children's life. Second is multiple vessels. They are children which, if they're teenagers, probably we can do this, but mostly it is the risk of thrombosis of a small vessel compromising kidney function. This we have to think very carefully and probably not offer these organs for children. If the donor have underlying diseases like diabetes, hypertension, I would encourage very carefully for all of us to look and see if these organs are able to be transplanted on children. In our center, any diabetes or hypertension on the donor is not a qualifier for transplantation, and we would not use this organ for transplant for children. Or immunological match. As you know, with the immunosuppression that we have now, we probably can compensate for a lot of the mismatches that we do every day. But when we think for small children, we should try to optimize the match before offering organs, and at least a poor immunologic match should be a consideration for non-transplantation on a small child. With the new advent of new antivirals, we are thinking that in adults, we can probably use some of these donors with high-risk behaviors, high drug abuse, high-risk behavior. In children in our center, we consider this a not usable organs for children for obvious reasons. Next slide, please. Next slide. Our optimal outcome that we want is to bring the children to the highest performance, accomplish their goals in life, and most important, to see life with a great outlook. This is a very good point that we have tried to discuss today, that probably we need a lot more in the future to talk about it and to really optimize pediatric transplantation to offer them the best quality of life in the future. I really appreciate the opportunity to be with you today, and I appreciate very much your attention today. Thank you.
Waldo, thank you so much. That was a fantastic overview of the issues around difficult decisions in pediatric transplantation. Do we have questions from the audience? Yes, Pankaj.
Hello. Oh, great. Thanks, Prof. That was a really, really fantastic talk. I just one very quick question. Are there any surgical conditions in your experience where you would not transplant?
Steve Martz here. That was excellent. Thank you very much. I was going to ask you about your comment about Wilms tumor, because it's written everywhere, Les, you've got to be more than 2 years into remission. But in fact, when we contacted the European database to find where the evidence was there isn't very much. We're changing microphones, I think. So just saying the Wilms tumour less than 2 years you can't transplant if they've been in remission. But when we actually looked at the evidence, the literature, it's actually not written anywhere. It's one of those things which have gone down from mankind in oncology. And we went to the Israel Pain database to see if there had been transplants, because we had a child who we were having difficulty dialyzing, and we actually were successful in transplanting. Maybe we were just lucky, and we did more keen monitoring afterwards. But I was just wondering if there is an American guideline based on that, or where you've come for the 2 years.
Well, for Wilms tumor, we have had several cases of Wilms tumor, bilateral Wilms tumor, in which we have had a very close relation with the oncologist to try to get some ideas of the behavior, the oncologic behavior of the Wilms tumor on these specific children. If they behave in a way that they're very responsive to chemotherapy, they don't appear with distant metastasis, we are able to diagnose that, well, we consider this good behavior. We transplant them even with bilateral Wilms 2 years after transplant. After initial surgery and treatment, when we consider the tumor is completely under control, 2 years later we transplant. As a matter of fact, we have 2 patients on the list right now waiting to accomplish the 2 years for transplant.
Thank you. Waldo, can you maybe just expand a bit on your approach in MMA? Where some of us are meeting later on today to discuss a case. And as you know, it's quite a difficult area to decide whether or not a liver or a combined liver kidney or a kidney first is the best approach.
Okay. Well, thank you. That's a great question. We have struggled for MMA for about the last 10 years of my career. We have had to struggle with it. And if you look at methylmalonic acidemia, it's one of the worst organic acidemias that we can find together with propionic acidemia. And the reason that it is a multisystemic. Every cell of the body is affected by methylmalonic acidemia as well as organic acidemia. So when we have that concept, when we look at transplant, we are number one priority is to preserve neurological function. In some of the areas in the beginning, the transplant was waited until there was renal dysfunction to offer kidney transplant. But in analysis, the most important disability that these children will ever have is delayed development and severe neurological injury along the time. If you look at the best medical control, your MMA fluctuates so much between 200, 300 baseline to 1,000, 2,000 and crisis overall really deteriorates completely the whole neurological system. So in our institution, these are the parameters. If we have a patient in which has had crisis, metabolic crisis, and suffered neurological damage, these patients will be considered at the time of diagnosis if it's difficult to control the disease liver transplant from the beginning. Now, the second scenario is that these patients have had a long-standing disease and developed renal dysfunction. We consider any creatinine clearance, systemic state, or glomerular filtration rate less than 50 mL per meter square a candidate for combined liver kidney. Now, the issue that we see in our patients is that if you transplant kidney alone, you may have a few years of good control. Because the protein restriction is so extended, you cannot change the dietary restrictions enough that it will improve the quality of life of these children. So, yes, kidney function and creatinine clearance less than 50, we opt for dual organ transplant these children. So, we have had patients in which we have transplanted with a creatinine clearance between 40 and 60 just for liver. And looking at our statistics, we have seen that by 4th
Okay, thank you very much indeed. That's very useful. Okay, I think we're going to need to wrap this up. Waldo, thank you so much again. Really, really appreciate it.